Hello folks, how are you? I'm here actually in New Hampshire. I've arrived again for the weekend, another weekend, just spending a little bit of time away from the city, enjoying time here in New Hampshire, a little place out here. And I figured, we have beautiful weather, well, kind of ski weather, lots of snow and things like that. It's been kind of very interesting weather out here in the mountains. I figured I'll spend a little bit of time here with you on this kind of Friday questions to do something I normally don't do, which is to just kind of go in, take a look at a few of the comments that have been out there and just give you guys a little bit of reply on these questions and see if it is of any help and if this is something that is helpful, since some of the questions can help everybody else, but they're kind of comments in the bottom of the videos and not everybody gets a chance to see them. I figured if I just put together a few of these questions from time to time and go over them with you, that it might be of some help to everyone, kind of question and answer these live with you. All right, so let's go on the first question here. Hi Doc, how's local anesthesia buffering by sodium bicarbonate 8.4% work for decreasing onset and painless injection? And what is any effect on the nerve block? So the question of buffering of the local anesthetic has been pretty hot over the past decade. Lots of people have been talking about it talking about the immediate buffering and injection. There have even been devices that have been kind of introduced for you to be able to mix your anesthetic and inject it. Of course, we understand what the buffering concept is all about. The idea here is that our local anesthetics that contain catecholamines, the catecholamine component is very important because it increases the length of anesthesia. The lidocaine plain, without any epinephrines, duration of anesthesia is very, very short, literally just a few minutes. But the moment you add the catecholamine to it, then you can have length of anesthesia due to vasoconstriction that can go on for about 60 minutes for one carpule of 1 in 100 epinephrine. Problem is that in order to put that catecholamine in there, you have to acidify the solution so that it can have a long shelf life. Otherwise, the catecholamine will break down. It stays on the shelf longer if it's a more acidic solution. Unfortunately, the acidity causes two problems. Number one, carpule of mepivacaine or lidocaine 1 in 100 could have a pH that's as low as like 4, and that is fairly acidic, and that can cause that burning sensation that can occur during the injection. That's very uncomfortable for the patient. But a more important problem is not that having pain during injection is not important, it's very important. In fact, I emphasize that in my anesthesia course. But the other problem is that by having a very acidic environment in your local anesthesia, you'll increase the cations. You have a lot of protons that are free, and these protons are going to make your actually the anesthetic molecule, the active ingredient, more in the which is your amide anesthetic in a more cationic form that prevents its crossing of the lipid membrane of the nerve. So since anesthetics work on the inside of the nerve, and that's how they block the sodium pump, getting too much of a ionic form of it outside the nerve will prevent its crossing of the membrane. So therefore, when you have a catecholamine anesthetic, which has a lower pH, you will kind of delay the onset of anesthesia. It takes a few minutes. So when you give a block with lidocaine, you got to wait 10 to sometimes 15 minutes based on these studies. But once you buffer it, which means that you kind of reduce the acid component of the anesthetic, then you get a shorter onset of anesthesia, and that is true. That is what ends up happening in these kinds of cases. So buffering is going to hopefully help expedite the anesthetic onset, but whether it is going to make the anesthesia more effective or not has been controversial. There have been studies that have kind of shown both sides of the spectrum here. We've had conflicting results. It's not quite really clear if you're going to have a better efficacy of anesthesia. Most likely not, because the component, the amide anesthetic component part of the anesthesia doesn't really change. Whether it's painless, more painless or not, also because of the lower pH, has also been somewhat questioned through different research as well. As usual, as it is the case with most of these studies, especially things that are as subjective as pain, you really need to have studies done with a very large population size, which we unfortunately don't have in endodontics, so this kind of keeps it unclear. Now, I tend to do this kind of a buffering with a protocol that I use routinely in doing endodontic anesthesia, which is by administering a pH-balanced, non-catecholamine containing anesthetic, such as mepivacaine plain, as a first shot, and what that does is it gives me tissue anesthesia, and then I wait 1 minute, and then I go ahead and give the actual shot with a catecholamine-containing anesthetic. I use mostly articaine or septicaine, 1 in 100 or 1 in 200, depending on what I'm using in the patient's medical history. But you can use xylocaine or lidocaine, 1 in 100 as well. So what this does, by giving what I call that pre-anesthesia, which is I use mepivacaine plain, which doesn't contain any catecholamine. What that does is it gives me tissue anesthesia so that the subsequent shot is going to be painless because I waited a minute from the first one, and I administer the first shot with a thin needle, and what that does is it helps reduce the kind of pain that the patient's going to have with the subsequent shot. This is a very kind of complicated thing that I talk in detail in the advanced anesthesia class and lecture that I give at our school, at Harvard Dental School, with our pre-docs, but here just suffice it to say that I have had very good results by using a mepivacaine plain carpule first, and then waiting 1 minute, using a timer to confirm that it's, we've waited enough, and then going in and giving an adequate dose of a catecholamine-containing anesthetic. For blocks, lower blocks, I give 2 carpules for a block, and then 1 carpule of buccal infiltration. And I do use combination, mostly I use actually articaine with 1 in 100, even for blocks. And I know some people talk about the paresthesia and things like that, but that's a controversial subject that is, I talk about it in my courses. It's not something that I want to talk about here, but that is a safe anesthetic to use for blocks as well. But if you don't feel like using that's fine. Just use lidocaine with 1 in 100 for the blocks. But the key is the volume, 2 for a block and then 1 buccal infiltration. That has been shown to increase the success and the efficacy of the anesthetic if you do give that buccal infiltration. So overall 3 carpules, and then also a little half a carpule of mepivacaine plain at the beginning to do some tissue anesthesia before the block. The same thing with the maxillary PSA blocks and the other blocks. I always use that mepivacaine plain with a thin needle at the beginning so that I can have tissue anesthesia, and then a minute later and I go give the shot. And invariably patients say that it was a very painless shot, and that's only because it created adequate pre-anesthesia above and beyond what a topical can provide. Now, this is an area, again, as I said, the course is very long in anesthesia, but I just wanted to kind of touch the surface of that here. And I'm in the process of creating some more detailed courses on basic endodontics here that I will be sharing with you guys later on. But for now, let's just talk about the surface of it here. All right, so another question here. When do you choose reciprocation versus continuous rotation? Now, that's another good question here. The idea here is that rotation is always the most efficient way for instrumentation because it is a constant type of a positive cutting direction. So you do cut a lot more of the dentinal surfaces in this angular rotation version of movement in your instrument. But as always, like in anything else in life, it is a trade-off. What you gain in efficiency, then in the wrong hands, in a inexperienced hands who's going to push too much, you may actually increase the torque on the file and then potentially increase the chances of procedural error, such as instrument separation. So what you are gaining in efficiency, you may be to a lesser extent in the wrong hands lose in terms of safety. So what do? The reciprocation motion was a kind of a compromise introduced by some companies and so on in order to help improve some of the safety of instrumentation. Of course, as I mentioned, due to the trade-off, it comes at the cost of losing efficiency. So what you need to do is you need to kind of figure out the decision of whether you want to do efficiency versus safety is a function of your level of experience. Most endodontists obviously would be using the more efficient instrumentation, which is rotation. You can add a little OTR to it, then you can control the OTR level at different levels so that you can increase your efficiency or safety. Pure reciprocation, which is just the torque independent motion of asymmetrical motion in one direction for cutting, and then a relief angle in a different cutting, and always the cutting action is larger than the non-cutting action, is, as I mentioned, as a compromise. It is designed for the less experienced operators because it helps increase your safety. Now, what I tried to do by helping design the EndoSync Plus handpiece is to be able to allow this motion of previously existing OTR motion to be combined with reciprocation as a concept, so that now you can get a torque-dependent reciprocation. So what this motion allows you to do now with the EndoSync Plus handpiece is that it allows you to be able to decide based on a given case what level of safety. You can optimize your level of safety, but by setting your OTR torque limit. If you want to have the training wheels on for the whole way, set the torque limit at the lowest on the EndoSync Plus at 0.2 Newton centimeter, so that it's doing rotation, but the moment it hits the dentin, starts to do its reciprocation motion based on the angle that you choose. And as I mentioned, you can choose somewhere in the order of 180 degrees for cutting direction and 60 or 30 degrees in the non-cutting direction, so that you can actually achieve your cutting motion. Now, if that canal that you're dealing with is a lot simpler, what you could do is you can set that torque limit a little bit higher. You can go from 0.2 to 0.4 to 0.6 to 0.8 to 1.0 all the way, where you get a lot of cutting action. So I would say if you're a general dentist and you really are prioritizing on safety, somebody who's new, when you're using the EndoSync Plus, set it at the lowest OTR torque limit of 0.2, which is the one that I'm going to help set the memory settings for. The memory setting 3 for having this OTR set to the lowest level for a reciprocating file, which is cutting in a reverse direction. If you're more experienced, what you could do is you could bump up the OTR torque limit from 0.2 to 0.4 to 0.6, or all the way up to 0.8 or 1.0 for far more cutting before that reciprocation motion cuts in. So that gives you a lot of versatility and capability. So the decision, again, going back to the question of whether you should be rotation or reciprocation, is really a function of your own level of experience. And pure reciprocation, I think, is for the very novice people, and pure rotation is for the experts. And I think OTR motion and the reverse OTR motion, which we put into the EndoSync Plus here, is really the whole idea of using this idea of reciprocation at the one end and then the rotation at the other end, and be able to kind of settle in the middle to have an idea of rotation and reciprocation that will be torque dependent based on your level of expertise. And I think that's a great compromise that allows both the novice and the experts get the benefit of that safety and efficiency, and hone in and fine-tune that level that is adequate for their own level of expertise based on that specific canal that you're dealing with. And that, in a sense, is the ideal of customization of your treatment in terms of motion for a given canal. And that's what we're trying to achieve here. All right, so another question here is actually related to the EndoSync Plus. It says that if they saw in one of the videos that I was making is that when I reach working length, the file stops 5 to 7 seconds, and that's not something good that they don't want to see that. That's going to reduce the efficiency. That is true that if that was the only option you had, it would be a problem. But you can fully customize, again, the handpiece and its motion. This is an area called apical action. If you put the handpiece on so that it comes to an apical, if your apical action is on, then you get to choose what kind of apical action you want to have. You can have apical stop on your motion, which means as soon as you reach the apex, the handpiece being connected to the apex locator is going to let you know, and that file comes to a stop. I have it set to a stop at the beginning because when I reach the apex, I want the file to come to a stop so that then my assistant can adjust the stopper to the full working length with a reference. Now, you can do also is you can then later on either change it or have another memory setting set up so that you achieve no apical action, so that as you get down to the apex, you hear the beeping sound, but the file doesn't change direction or do anything. You can also set it up, instead of apical stop, to apical slow down, to apical reverse, and those are other options too. I don't like the apical reverse option because I don't want the file to reverse, as it would then push debris out. You might as well have the apical action to off, so all you do as you're going close, you will hear the beeping sound, but you don't see any change in the action. So as you hear the beeping sound, it would be your wrist that is going to be kind of giving feedback and push the file back as you're getting closer to the full working length. So here it is, that's the key thing to keep in mind. There's a lot of versatility and customization that is possible with the EndoSync Plus, and that's why I love that handpiece. The next question here is, are you supposed to get a sealer puff at the apex? Well, let's understand, this is a very, very long conversation. In the treatment planning seminars, we've recently had this long debate over this whole area at our school with the residents. But the idea here is that let's keep in mind that the sealer puff or sealer has absolutely no business beyond the cemento-dentinal junction or the constriction of the tooth. It really doesn't do anything. Historically, based on the Boston School of Thought that was kind of promoted by Dr. Schilder, the idea here was that having that puff would validate that you have filled to the apex. It was a necessary evil, if you will. But I think that's a moot point at this point, since we have apex locators, and many of the researchers now showing us that apex locators are more accurate than your radiographs. So you really don't need to have a validation through a sealer puff. You just have to cling to where the apex locator is saying, and as long as it's reasonably close to the end of the root, within a millimeter or so, then you know that you are probably at the apical constriction. You don't need to instrument all the way to the RT, which is a radiographic terminus, which would, in many cases, based on the work by Cutler and so on, has shown us it would mean that you are actually out. So let's trust the apex. So get a good quality apex locator and then trust it, as long as then check with the x-ray as well to just have that additional confirmation, because at times you can get false positives due to lateral canals, due to some type of a coronal short circuit you could have with an instrument or with some filling, a conductive filling or a crown. It's always a good idea to have an x-ray combined with your file for a file shot with your apex locator, because you will have an additional level of certainty. Plus, don't forget, as I've said this in previous videos, a file shot will give you information that your apex locator does not give you. For example, what kind of curvature you have at the apex, and that information is really helpful in terms of your decision making about gauging and deciding what your master apical file size should be. So that's an important factor as well. So there's a bunch of other questions here too. Could you, Con here wants me to make some videos for wave 1 and gutter core, as well as what are some malpractice cases, what kind of cases you can get in trouble with, supply, order, and organization, very important, creating systems for efficient workflow. So these are all great questions to make and make videos on. I hope to make some of them. Of course, the question of wave 1 versus gutter core, the equivalent on the wave 1 is our ESR, not the ESR-CM, but the ESR. And the gutter core is essentially another obturator type of filling. And certainly our system is hydraulic condensation. I have never actually used gutter core, but the concept of gutter core is the same concept of thermoplastic obturation. So if you do believe in warm vertical condensation and the need to do thermoplastic techniques, then things such as conventional vertical condensation obviously would be best, but simpler techniques such as thermofill and gutter core are the ones you would be using. The only problem I have with that is that, as we know, gutter core and any of the thermoplastic techniques, you have a shrinkage of the gutta percha that occurs over time. And in fact, if you do any of these techniques with thermofill and gutter core in a clear plastic resin block and you fill it, it looks beautiful. But if you leave it there and come back and look at it in another hour or two, you will see that the gutta percha is going to move away and shrunk a little bit from the walls. And that's just due to the conventional, what we've known for years, which is the shrinkage of the gutta percha during cooling, which has been the reason why Dr. Schilder developed vertical condensation technique in such a way that you would add little aliquots, you heat up the gutta percha, and you condense it as it's cooling so that you can compensate for the cooling shrinkage by condensing it during that time, or compacting it, if you will, a little bit more accurate term for that. But the other thing with most of the carriers is the cost issue, because Each one of these carriers, I don't know what they cost in your neck of the woods, wherever you are in the world, but here in the US, they cost anywhere from $10 to $12 a carrier. So if you're doing a obturation of a molar with 4 canals, you're just spending $40 on the obturator alone. The sealer goes on top of that. So all of a sudden, the cost is incredibly out of control here. If you're spending, $40 on obturators and another, $5 to $10 on your sealer because you do need to use a sealer anyway still in these cases, then all of a sudden you're talking about a lot of money going into the obturation phase. What's actually interesting that leads to a whole different conversation about the cost of obturation. People often forget that the people talk about these bioceramics being expensive, but they're actually not if you think about it in terms of the per canal usage, and the fact that you're getting rid of many of these big thermal devices such as your backfilling gun and the thermoplastic techniques that you need to use for that. Plus, if you're using obturators, that's not even a comparison. The cost is tremendously more if you're using an obturator, whether you're using hydraulic condensation, using bioceramic sealers. So what we need to do is we need to be a little bit better aware of accounting terms and how do you calculate the cost per canal to do one procedure versus another, not just based on the retail cost of a syringe of sealer, but having this cost of the syringe of sealer on the other side, plus the obturator costs, plus the devices that are needed to support that technique, such as the thermoplastic guns and things like that, and in order to come up with a cost of it. If you're interested in me having to do a little cost analysis for you on that, let me know in the comments, and I may do a little cost analysis comparing exactly bioceramics versus obturator techniques for filling. So malpractice cases, that's a significant, obviously, an important part of what we do. Every general dentist doing going out there, as well as endodontists, we're all trying to avoid cases that are treatment planned. Treatment planning, part of the treatment planning is doing what is necessary for the patient. And another important part of it is also knowing who should be doing it so that you can maximize the care and the outcome for the patient. And to that extent, we need to be aware of what we're capable of doing, how much experience we have each our own in terms of managing specific cases, and then having good relationships with our team in a treatment team for the patient so that we can get the best outcome for the patient. To that extent, there are systems by which you can triage cases to find out what level of difficulty is too difficult, it should be done by an endodontist. And I should probably do a video on that. There's a few things with the case difficulty assessment form from the AAE, and maybe I can go over it or find someone who has nice representative cases that I can interview, and we can go over what kinds of cases are really endodontist cases, what kinds of cases general dentists should be able to do. And that's probably a very good video to make. So supply and order and organization. This supply order and organization, that's really a key thing, in fact, to help optimize your workflow in the operatory and in the office. And that is done at the level of your assistants and the office staff in charge of supplies. And then how do you optimize the workflow from a little bit of a supply side in your closet all the way to bringing the materials for use into tray forms, into various tub forms so that you can have procedures all in one place, do them, and then how do you deal with re-sterilization and put it back full. That's a workflow that's very important. I probably should do something like that for you as well as a video. These are great suggestions too. In my office, we use trays for everything. So everything is going to set up as a tray and it's broken down and so on. And in terms of usage, I've done a previous video. I say I only use files in 2, maybe 3 canals. So I just basically use them brand new, and then after it's one use, if it's not a molar, then it gets one little line on it. That means that it's been used once, so that the next time I'm using it, I know it's the last time I'm going to be using it. But every place around the world, I understand the limitations that are present in terms of cost and compensation. So you need to come up with what's optimal based on your own operatory. So Adam asked a very good question here too, in terms of what is when is it better to use a constant taper file versus a variable taper file sequence? Comparisons such as for taper versus vortex, and I guess the equivalent of those are the endosequence taper versus the conventional endosequence files. So the idea here is, when is it best to use a constant taper instrument versus a variable taper instrument? So we need to ask ourselves, what are really the indications for a variable taper instrument? Most variable taper instruments were designed originally to allow vertical condensation to take place. Now, vertical condensation required fat coronal shapes that would come down to a taper. So many of the variable taper files, including the pro-taper files, create pretty large coronal shapes in order to accommodate condensers that are supposed to reach the apical 5 millimeter in order to implement vertical condensation technique. And to that extent, that's really the main impetus behind using a variable taper technique. Since we've moved as a constant taper instrument to a recommendation to use primarily 04 taper constant taper instruments and do not use any constant taper instruments beyond a size 30-06, we know that that realm of 04 constant taper and 06 up to a 30-06 is acceptable and can deal with pretty much all of your cases you're going to see clinically. So the question of when do you use variable taper versus constant taper becomes a question of really your taste and your training, and as well as your choice of obturation. If you're going to use a thermoplastic technique and vertical condensation, many people end up using those variable taper instruments. But if you're using hydraulic condensation, some of the other types of condensation techniques, of course you could do vertical condensation with a constant taper instrument as well. But generally constant taper becomes a little bit handier and easier, because the main difference between a constant taper and a variable taper instrument, in fact, is the ease of obturation. Constant taper instruments, it's a lot easier to do cone fitting because you have just the same exact taper. You can literally take one cone and keep trimming. You can start from a size 20-04 cone and keep trimming the tip and keep getting the next serially larger size cones with a constant taper instrument. That's something you cannot do with a variable taper instrument. Cone fitting is a lot easier in your constant taper preparations, as well as obturation as a whole being a lot easier in your constant taper canals. So those are the main reasons, but those are obviously some of the important concepts behind it. So I think this video has become already pretty long. I probably should do something like this some Fridays. If you think this has been helpful in some ways, let me know, and I will do more of those. So it's probably time to cut it off and continue maybe doing more of these. If you think this was helpful to you, let me know, and I will probably do something like this where I go over your comments on your questions that you put down in the comments below in future videos. Put that down in the comments right now if you have questions, and if you do want me to do more of these in the future, where I kind of just get together some of the comments and go over them at the same time through this little bit of a longer format. But it is getting too long, so I'm going to cut this off at this point, and then maybe do another one for you next time. So for Rivaldendo, and coming from the beautiful New Hampshire near Lake Sunapee in New Hampshire, I'm Ali Nasseh, and let's save some teeth.